Welcome to everybody. I think this is a very wonderful session. We are very delighted to be invited for this session, and we have a lot of interventionists from different territory join this session. So because of time limits, we have to proceed for the first speaker from Israel, Dr. Goldberg. Probably you would like to presenting the first case, complicated left main. Please, Dr. Goldberg.
Thank you for the opportunity to present this case in this meeting. And the case is about the complicated left main intervention. Let's go on. Okay, so I don't have any conflicts of interest to disclose. And we're speaking about the male patient, 79 years old, very good general condition. A year ago, he had a catheterization that showed borderline left main disease and significant LCX and marginal disease, as well as CTO for RCA. He refused the cabbage, so the stenting of LCX and OM was performed with good result. Now he presented with typical angina on dual anti-ischemic treatment with beta blockers and calcium channel blockers. His echo study was near normal, and he had the exercise stress test positive for ischemia with high risk features. His coronary angio showed the distal left main 70% stenosis, patent stents in circumflex and marginal, and very good collaterals from diagonal to PDA branch. The IVUS to left main was performed with a minimal lumen area of 3 square millimeters. So this is the angio. You can see the calcified distal left main stenosis. Very extended one. And we again spoke with the patient and his cardiologist, and it was decided that we proceed to the left main PCI. So after we did the predilatation with the 2.5 by 12 balloon, we've got a dissection in both direction of both LAD and circumflex with slow flow, bradycardia, and shock. Immediately, he was started on dopamine, atropine, and fentanyl because he had a severe chest pain. We promptly put the onyx stent 3 by 15 from left main to LAD. And we've got a good flow in LAD, but a compromised flow in circumflex. We did the proximal optimization with non-compliant balloon 4 by 8. And the flow in circumflex was complete cessation of the flow. So we did the PTCA with a 2 by 12 balloon underneath the stent struts that was in the left main to ostial circumflex with the restoration of the flow in circumflex. And then we had difficulties to rewire the circumflex through the stent struts. Therefore, we put the third wire to the ramos and dilated the stent struts a bit. And then the rewiring on circumflex was performed finally with the balloon inflation of 2 millimeter balloon with some improvement, both in the chest pain and hemodynamic. But as you see the hand of the patient moving towards his heart, he wasn't feel very well. Then we performed the T-stenting of circumflex with Ultimaster 3 by 12 stent. And then we did the kissing balloons and the proximal optimization with non-compliant 4x8 balloon. The final angiographic result was good, and his hemodynamics improved rapidly. He was transferred in ICCU with the tirofiban infusion on top of the dual antiplatelets therapy with aspirin and clopidogrel. He was completely asymptomatic, but as the intervention was complicated and done in not optimal condition and no intracoronary imaging was performed, we decided to do the second look coronarography. And to our surprise, he had a thrombi on the bifurcation in direction of both the ostial LAD and ostial circumflex, despite that he was on triple antiplatelet therapy, that you can clearly see on the video in the still recordings. We performed IVUS that showed us good stent apposition, but under expansion of stent in circumflex. We again did kissing balloons with 3x12 and 3x15 semi-compliant balloons, and again the proximal optimization. We had a good angiographic result, and we substituted clopidogrel by prasugrel. We performed echo during the hospitalization that showed a little reduce in the ejection fraction, inferolateral wall motion abnormalities, and moderate to severe ischemic mitral regurgitation. The echo was repeated in 3 months with very mild inferolateral hypokinesis without any MR. He was asymptomatic except of mild dyspnea. We performed again the coronary angio, and the stents were patent. So we switched back from prasugrel to clopidogrel. And this is the 6 months coronarography that was performed during this hospitalization because of a little bit of dyspnea with and we were extra cautious to look again on his coronary angio. Okay, now his follow-up is completely uneventful. So what I would like to put in the take-home message, that the calcified eccentric distal left main lesions are prone to complications. And in the case of acute branch closure, the PTCA underneath the main branch stent might be very useful. And in case of complicated emergent left main intervention, a second look coronarography with intracoronary imaging and optimization is strongly advised. Thank you for your attention.
Thank you. Any question? Because we about 6-7 minutes presentation, and we have 3 minutes maybe to question anyone. To Dr. Cho from Korea. Korea is a very good technique for the left main. Yeah. Any suggestion?
I think first, in my opinion, I usually first treat the right coronary CTO, and then because in this situation, left main is unprotected situation.
So unprotected, and RCA CTO.
There are some dissection or thrombus, very
very dangerous. Yeah. Okay.
I don't know how the situation is right to CTO. But in my case, I will first treat the right CTO first, and then if it is fail, I will treat the left side disease.
Maybe any defense for suggestion?
Yeah, we actually we thought that the right is not it can't be manageable by PCI. Therefore, we advised for the cabbage for the coronary bypass, but he refused, and we obviously we didn't expect such complications. Left main stenting. Actually, if I can share the screen again, the original plan was entirely different. Like we thought, because of the difficulty in accessing circumflex, I thought that it would be better to put the first step from left main to circumflex. But we had these dissections after the first pre-dilatation. We have to say what is more important at that point. Therefore, the stent was put to the LAD first. And also because these very good collaterals from diagonal branch to RCA.
Okay. All right. My comment is because this is like a Korean the speaker said, because this is RCA CTO, left man without protection, and also very calcified. 6 range, right? It seems we started with 6 range. Transradial or?
Yes.
You have prepared the groin or not? For example, any hemodynamic support, standby, or anything happen? Yeah.
We have the intra-aortic pump. We don't have impeller.
Okay.
And we usually, the long time ago, we used to sometimes put intra-aortic balloon on left main intervention, but it's quite a few years that we stopped doing that.
Okay, any other suggestion? Because of time limits, we have to switch to the second operator, second speaker. So any suggestion or comment regarding the presentation? If not, probably have to go proceed because of time limits. Okay, thank you for the Dr. Goldberg's very challenging case. Our second speaker will be Dr. Sasi Prafa from Thailand. It's a very long name, successful transcatheter thrombectomy in high-risk massive pulmonary embolism patient. Okay.
Today, I would like to share my case, successful transcatheter thrombectomy in high-risk massive pulmonary embolism patient with recent major cerebral hemorrhage. I have nothing to disclose. Now we have a 77 years old man which is a young man, have a underlying disease of diabetes and hypertension, which is very poor compliance. And he was admitted to the sudden alteration of consciousness and right hemiparesis. As you can see in the CT scan, it shows the large left basal ganglia hemorrhage here. And a week after the admission, he suddenly developed dyspnea at rest, and he needed endotracheal intubation. And he has hypoxemia and hypotension. And you can see in the chest rate, there's no infiltration that explain the hypoxemia, but the lung oligemia in both sides, especially in the right side. And now we send him to emergency CT scan for a pulmonary embolism. As you can see, the CT show an extensive large pulmonary artery embolism in both branches, and there's a light thrombi in the main pulmonary artery too. And the echo show a large and severe cystic dysfunction of a right ventricle. Now we have acute massive high-risk pulmonary embolism patients with a history of recent major hemorrhagic stroke. And the choices of treatment at the time, I think we could not use femorasis either in systematic or catheter-based in this patient because of the history of hemorrhagic stroke. And then we consult for surgery, surgical embolectomy to the surgeon, and the surgeon turned down because the patient is too sick and because he still have potential and need higher intrathrombin at time. Then we have, the only choice we have is a transcatheter thrombectomy in that time. Then we decide to do it. And we use the Indigo system. And this time, let me introduce some equipment. Here we have a CAT-F catheter. The S stands for 8 French here. And there is separator, a SEP-F here. And the last one is penumbra engine to create a suction effect to the catheter. Then we use the JR catheter, engage the left. We can engage to the left first, and then we switch to the 8 French long sheet, and then we inserted the CAT-8 catheter in this area and did a pulmonary angiogram. And you can see there is total occlusion of the upper branches and the lower branches of the left pulmonary arteries, as you can see in the video. Now let me show you how does it work in this system. We use the separator to break the clot and use the CAT-8 to suck the clot out of the body at this slide. And then we start doing the suction. Here we use the separator to break the clot and suction. And the repeat angiogram show a better of flow into the left pulmonary artery. But unfortunately, as you can notice that the heart is larry beating in this time because the patient developed a cardiac arrest after we did a left pulmonary thrombectomy. And ECG show a PEA, a bradycardia. As you can see the ECG in the slide, and he needed a CPR for 2 cycles and need a higher vasopressor after that. This is, I think this is the first learning point for me. If you can go back in time, if I can go back in time, I will fix the right side first because it's more severe. And if I put the left catheter into the left side, it can occlude some flow into the left side, and the patient could deteriorate that in this case. So we rapidly switch to the right side and do a pulmonary angiogram. But you can see the last thrombus here, and it's still made for you in the right pulmonary arteries, quite a big one. And then we do it the same manner to get rid of the clot as much as possible, and look at the lower branches and at the upper branches. Now we have a final angiogram. There's still a large clot, but a much improved of the flow, and the heart beating is much better in this video. And this is a clot that we can get rid of from the patients. There's a large amount of it. Before we end of the procedure, we inserted the IVC filter, and we sent him to the CCU. And fortunately, we could discontinue all neutrophil and extubation in 2 days, but good one. And the neurologist told me that we cannot give them any anticoagulation. As you can expect that 2 weeks later, the patient had bilateral legs edema. Then we repeat the CTA, and the CTA show nearly complete of the solution of the pulmonary arteries, but there are extensive DVT both legs upward to the IVC filter, and some of the clot break through the IVC filter too. So we discussed with the neurologist team, and we decided to prescribe the episband at that time. And the legs edema will improve after that, and the patient can go back home, and now he can walk with himself with partially with assistant and eat by himself with a good recovery of consciousness. And the echo show a reduction of RV size and good systolic function. Now let me sum up this. I showed you the cases of transcatheter thrombectomy is feasible in high-risk PE case with contraindication for fibrinolysis. And please never forget to deploy IVC filter, especially in case that you cannot prescribe anticoagulation after that. And if you can choose, please do the more severe side first. And the last one is this important to deal with complex case with a multidisciplinary team approach? Thank you.
Thank you for very challenging case. Any comments? Our cardiologist doing that peripheral procedure as well. So, Dr. Xue from Taiwan, any experience of thrombectomy penumbra for the pulmonary embolism? Dr. Xue? Dr. Xue, you are...
Yes.
Okay. Yeah, okay. Any comments or any suggestions? Contraindication of fibrinolysis. No comment? How much, Dr. Sasiprabhat, is how much for, how much for the whole device? Because this is, I guess, in Taiwan, this is very expensive. So patient have to pay how much for US dollars?
For US dollar is about 3,000 and 3,000.
3,000. Okay.
Yeah, 2,000. About 2,000 for whole system.
Any other comments regarding this kind of why the surgery don't refuse take this case? Because a massive, I guess thrombectomy only can partially release. You still needs the long-term, NOAC or anticoagulant in the future. But why that the surgeon don't like to take this case?
That's a good question. I think actually at that time the patient's blood pressure was only 70 over 50, around that, before we do the procedure, and the surgeon said they cannot get on time at the time.
Okay, maybe
too late for them.
All right, so thank you again. We are going to proceed. Dr. Yu from China is going to present the third presentation. Double CTO, please, Dr. Yu.
Okay. So thank you for the invitation to share the case today. So my case is a double the trouble and a case of double CTO with poor vascular access. So I have nothing to disclose. My patient is a 65-year-old. It is a he is a smoker. He had a history of ischemic heart disease, stroke, and also severe PVD with bilateral iliac disease. The echo, the EF is only around 30%. The patient had a history of PVD with CT angiogram done before, which showed total occlusion of the right internal iliac artery, entire right SFA, and also the left common internal external iliac arteries and SFA are also looked at total occlusion. So the patient presented to us complaining of chest pain for 5 years and also increase in chest pain in recent 1 month. So this is the choral of the patient. There is osteo left main, 50% stenosis, and also there's a CTO in the RCA and also in the LAD. As we can see in the choral, the LAD CTO has no stump. So what is your PCI strategy? So for us, we think that the LAD CTO is quite challenging for the integrate approach because the CTO has no stump. So we decided to proceed to the RCA CTO first to give a retrograde option for the LAD. So this is the final result of the RCA CTO. And because the patient have a severe peripheral vascular disease, we have to use a brachial access and also right femoral access through the PVD lesion. And this is the choral for the left side. As we can see, there are many options for the channel, but they are all very tortuous. And the proximal part of the channel is very tortuous, as we can see here. So we decided to use the turnpike. It did well in the tortuous channel. However, it is very difficult to cross the mid-septal channel. So our personal feeling is that we have quite a number of microcatheter, and for Corsair Pro, we think it is more easy to cross. However, for Turnpike, we think it is have a better support. So we decide to use the So we decide to use the Corsair Pro XS with a smaller profile to cross using the reverse card technique. However, as we can see here, it is very difficult to pass beyond this level. And we can see the catheter is also trying to disengage. So we use the Turnpike LP again. And we are able to pass the Turnpike LP back to the antegrade catheter. So in this case, we actually use two microcatheter, and because of different strengths in different catheter. And for Corsair Pro XS, it is more easy to cross. However, the support is less good compared to Turnpike in this case. So this is the final call of our case. And there's a good angiographic results in the LAD. So my conclusion is that the main challenge in this case is the difficulty in wiring the CTO body through the antegrade approach, and the difficulty in advancing the Corsair Pro and through the retrograde approach. So, however, we successfully managed to use the Turnpike LP to cause the guiding catheter retrograde. So I think in this case, we learned that combination of the microcatheters can help for the CTO in different occasions, as in this case. Thank you.
Or maybe any other? Is anybody doing a CTO in your practice? Dr. Cho is doing it because you mentioned about CTO for the first case. Okay, what is your suggestion regarding the case?
I first want to question why didn't to choosing for the surgery maybe the best option, because he had very low LV ejection fraction and also peripheral vascular disease very severe. So in the case, maybe surgery is I think, but the better option. So why didn't first consider the surgery?
Yes,
any reasons?
Because in our case, actually, surgery team turned down our CABG. Initially, we want to do this, refer the patient for CABG first, but the surgery turned down. So we have to proceed to the CTO.
But any consideration regarding you fix that the peripheral, because you have a team to fix the peripheral artery disease before we proceed for that CTO, because anything happen because a low ejection fraction, you do a retrograde, hemodynamic compromise. In our series of about 1,000 cases, we probably have 20% because a low ejection fraction, like LVEF lower than 35 or 40, then we need either IBP or sometimes ECMO. I know the Hong Kong you can use Impera, but however, you need still that femoral approach. So for this case, maybe if the right femoral still, we can go fix a peripheral artery disease. That is another option. Go Impera in, then you have another 7 French sheets. Then you still can do a brachial femoral combination with Impera support. Is that your practice, right?
It is a very good suggestion. Yes, I think we sometimes our support for the peripheral disease is not very good. But this is a very good suggestion. Yeah.
All right. Another option, because the recommendation is regarding that wire pass, but however, microcatheter cannot pass. So you switch from Turnpike low LP to Corsair Pro XS extra small. Of course, this is a good option, but sometimes we can use, in China, probably sometimes they cannot afford that kind of microcatheter, several different kinds. So in my practice, sometimes in China, if I'm doing a live demo, we can use very small profile, 1/0 by 6 10/5, just kind of pushing along with the wire, then kind of buccination of the microcatheter, especially in the mid-septum. That is very safe. Then after that, your turnpike can be easily to pass. That is, I have more than 20 times of this kind of event. So next time, probably you can try not changing the microcatheter, but you are using a small balloon to adjust the buccination. Yeah, that's my suggestion. Okay,
Thank you.
good. Yeah, excellent. All right. Any other comments or any other? We still have 1 minute or so. Or question, Dr. Xie, are you doing a CTO in Taiwan?
Not yet.
Not yet. Okay.
Not yet.
Okay. So if no other further question, thank you for the presentation. Very wonderful case. Okay. The following would be Dr. Kania Pa from Malaysia, right? Okay. So the title will be The Road Less Trouble. Okay. Please share the screen. Less trouble. Okay.
Okay. A very good day to all the distinguished panel. First of all, I would like to thank TCTAP 2022 for giving me this great opportunity to present today. I'm Kogala Krishnan Kandiyapan from the National Heart Institute, Malaysia. And my presentation today is titled The Road Less Travel. I have no disclosures. First of all, this is a 62 years old lady who presented to us with a chest pain for 1 week with a recent history of admission in another hospital for unstable angina. Pre-morbidly, she has a history of coronary artery disease where a PCI to the left main, LAD and RCA was done in 2016, followed by another PCI to the ISR LAD done in August 2020. Otherwise, she has diabetes mellitus with HbA1c of 9.2, hypertension, and dyslipidemia. Investigation that was done in our center showed hemoglobin of 12.6, platelet of 240, renal profile, creatinine was normal, TROP-T was negative, fasting lipid showed a LDL of 1.8 and a TG of 2.3. Liver function test was normal and HbA1c was high, 9.2. Our electrocardiogram showed a sinus rhythm, normal axis, Q wave in lead 3 with no evidence of ST changes. Other investigation that was done, we did a chest x-ray for the patient which showed cardiomegaly with a clear lung field. She had an exercise stress test which was done in another hospital which was positive at stage 2 where there was a ST depression in the lateral leads. Echocardiography, which was done here, showed a LV ejection fraction of 55% with the evidence of anterior wall hypokinesia, normal diastolic function with a TAPC of 1.7 with no evidence of LV thrombus. We counseled the patient for an angiogram and we subjected the patient for angiogram on the next day itself. This is the angiogram done via the right femoral approach using the catheter JL4 and the JR35. If you can see here, the left main, there is a mild instant restenosis. There's a severe instant restenosis of the proximal LAD stent and a very calcified vessel. Third, there's a severe osteal disease and RCA, mild instant restenosis. At this point, our plan of treatment would be to proceed with a PCI to the LAD. Via the right femoral approach, we use the EBU 306 French guide. Our run-through floppy managed to cross the lesion, and we did an IVUS run. The IVUS run showed the left main stem, there's a presence of calcium in one arc with a mild instant restenosis. The proximal LAD stent, however, showed calcium in two arcs with presence of calcified nodule at around 3 o'clock position. The proximal LAD stent measures 3 to 3.5 lumen to lumen, and left main size was around 4.5 mm lumen to lumen, and the MLA was 4.75. At this point, we pre-dilated the proximal LAD with an NC3O of 12 at 12 atmosphere up to 14 atmosphere, but the balloon slips multiple times despite multiple attempts that was done. We were unable to expand fully due to heavily calcified lesion, as you can see here. After a few attempts, we decided to abandon the procedure first. At this point, the decision was that the patient was hemodynamically stable. We noticed from the angiogram it was a very calcified vessel. Despite multiple attempts of pre-dilatation, we were unable to extend the lesion properly, and we know that we might not be able to achieve a good results. So we wanted to stage this patient for a PCI to LAD with usage of intravascular lithotripsy to treat the calcified lesion. So we discussed with the patient, we told the family members, and the family agreed for a staged procedure. We brought back the patient in 1 week time. We did the angiogram via the femoral approach again. At this point, we used a EBU 307 French, run through prophy, wired into the LAD, and cyan blue into the left side. This is the OCT which was used to assess the LAD, but unfortunately, the first OCT pre-PCI, there's a lot of blood swirls, so the images were not clear. But to make things clear, I have taken a few pictures here to show that there is a very deep calcium in the proximal LAD, almost around 2 quadrant, and also evidence of the nodular calcium were also seen. The proximal LAD was also shown to be underexpanded. This could be the reason for the instant restenosis. The proximal LAD lesion vessel size was around 3 to 3.5 with a luminal size of 2.5, and the left main stent also showed similar finding from the IVS where there was a mild ISR seen. So now we try to pre-dilate the left circumflex first with an NC2012. As you can see here. Then we decided to bring the IVL shockwave balloon into the LAD. So we used the IVL shockwave balloon 2.512 inflated at the subnominal of 4 atmosphere at the proximal LAD. 4 sets of 10 pulses were delivered from distal up to proximal stent edge of the LAD balloon. At this point, you can say the balloon is well expanded after the 4 sets of pulses itself. Now what we did, we used the same IVL balloon, we advanced the balloon into the left circumflex, and we used the same IVL balloon to cross the osteoproximal segment, and another 4 sets of pulses were delivered at 4 atmosphere at the proximal cert. And we were able to achieve a very good balloon expansion after the delivery of the shockwave balloon. So this is the OCT run done into the LAD after the IVL. As it's coming through the proximal LAD stent, you can see multiple small mini fractures seen within and beyond the old stent struts. So our shockwave balloon able to prepare the vessel much better than what was achieved earlier. This will help us to get a good outcome when we deploy our drug-eluting balloon later. So next, we did the OCT run into the left circumflex. Here also there is evidence of calcium fractures seen within the lumen with a fibrofatty plaque were also been well prepared in the osteoproximal segment. So now we then continue to pre-dilate the left main, left anterior descending, using the NC3015 at 12 atmosphere, and also again pre-dilate the left main with the NC3515 at 18 atmosphere. Then we proceeded with the pre-dilatation of the osteoproximal cert to prepare the lesion with a NC27523 at nominal pressures. Now we stented the left circumflex with a drug-eluting stent 2.7523 at nominal pressure and post-dilated with a NC27515. Now what we did, we reverse stretched the left circumflex stent with an NC balloon which was placed in the left main. We flip-flop the wired and rewired again into the 2 vessels, circumflex and LAD. Now we perform the kissing balloon inflation. With LED, there's a NC3515 and a circumflex, there was a 27515 balloon. This was the results after the kissing balloon inflation. And then we proceeded with a deployment of a DEB 3015 into the proximal LAD at nominal pressure for almost 60 seconds. Then DB3525 deployed the left main LED at a nominal pressure for 15 seconds, which was done sequentially twice. And a final port in the left main with the NC408 for 10 seconds. And this is our final results. You can see the left osteoproximal cert has much improved luminal gain, and also the LAD calcified lesion, which was narrowed or much better now. With the T-metry flow, patient was hemodynamically stable throughout this procedure. So this is a final OCT run done post PCI. It showed well-opposed strut with the minimal residual stenosis, and we were able to achieve a very good result in this case using our shockwave lithotripsy treatment. So as a conclusion, what we wanted to highlight in this case is that the novel usage of IVL in severe ISR with a background of coronary artery calcification is a viable and a safe option compared to other atherectomy devices. We know that the usage of rotablation, OAS, there's also a risk of dissection, there's a risk of distal thrombus, and also a risk of perforation. There were evidence based on the DISRUPT trial showed the risk conquered by using the IVL is much lesser, and the shockwave acoustic pressure waves are supposed to be tissue safe. The deployment of same IVL balloon catheter in two different vessels is what we have done in this case, is something feasible and effective as demonstrated in our case. And further prospective trial and clinical evidence, however, is required to review and expand the indication of IVL in such selected cases. As of now, IVL is only been recommended for single usage in a vessel. So I will thank you for your time.
We had a little bit over time for presentation, so I'd like to invite Tanawat Suiset because he raised hands at the previous presentation. So IVL is available in Thailand?
Yes. No, IVL not available in Thailand.
Okay. But any comments regarding this case?
Yes. For this case, in Thailand, we use rotabator in most cases for calcified lesion in Thailand. But in some center, we have the very high pressure balloon to overcome the calcified lesion, and to focus force balloon, we have to most available also in Thailand. But I have some question for this case. In left main segment, do you use the code balloon or diluting stent for the left main segment for this case?
Sorry, I didn't get the question.
You didn't get the question. Okay. Say it again for the questions regarding left main.
Okay. I'm not sure in this case, you put diluting stent or duct code balloon for left main segment.
TCB for the left main. Yeah.
This patient in this particular case, this patient has underwent a few procedures prior to this. She had this stent already in the left main up to ostial left main to the proximal LAD before these two stents were there, and the cert lesion was not treated. And in 2020, as I mentioned earlier, she had also developed another severe ISR where she underwent a PCI with a duct balloon. So this time we wanted our initial strategy to perform a PCI with a drug eluting balloon to the left main LAD, but we noticed during the first IVS run, there's not only a calcium, superficial and deep calcium in the left main, and also mostly in the proximal LAD. However, the stent were not well expanded due to the nodular calcium. And we know that probably there's another option of using a high pressure balloon like a OPN balloon in this case, but this patient already came multiple times for ISR, and we wanted to prepare this patient well so that this does not recur again. That's where the decision of staging this patient for a lithotripsy treatment was taken.
Okay, perfect. So we have to proceed. Thank you for the presentation. And next speaker will be Dr. Xie Subo from Taiwan, right iliac artery extravasation. Dr. Xie, please.
Thank you for the opportunity to present a challenging case report, which is right iliac artery extravasation. I'm a medical doctor from Taiwan National Chang'an University Hospital. This is a 44-year-old female patient. She had received a mitral valve coda tendon rupture, which is received a Da Vinci mitral valve repair surgery on 2019 and June 9. And she had an independent activity of daily living. This time, she presents an intermittent right lower limb shortness on exertion and limping for 1 year. So arrange a CT angiography for the symptoms, and it showed that her right external iliac artery from the proximal to the distal part is total occlusion. And so angiography is indicated. So we arrange right iliac artery percutaneous angiography, which shows that this is the right iliac artery, then this is internal iliac artery, then this is external iliac artery. So we can see that the CTO part is from the proximal to the distal part. And so the strategy is due to the total occlusion part is from the proximal. So we do the crossover integrate approach from the left iliac artery to the common to the internal iliac artery. We show that there is no collateral artery to the external iliac artery. So we put the retrograde wire with a thermal and phi thermal wire and phi 18 or Aristotle wire support with CSI support catheter, but failure to cross through the CTO lesion. And because the patients cannot lie down very long time, so in agitation, so we close the procedure, then do another time. And it's 3 months later, we do the same angiography, which show there's still total occlusion. And we measure the proximal diameter is about 6.3 millimeter. So we do the retrograde approach with a startle control wire, which is 0.018 inch, total 3 inch, but we cannot cross the right dimension. So we use another wire with 318 control wire with CSI support catheter, but we're still unable to reach the proximal external iliac artery ostium. Then we use the much power thermal wire with CSI support catheter. Then we cross the CTO lesion successfully by the crossover integrate approach. And we need to make sure the wire is in the true lumen. So we're converting an integrate wire in the true lumen with the same dimension with different angle. So in the first place, we use the Mustang balloon 3 millimeter to dilate CTO lesion with 6 to 8 millimercury to the right external iliac artery, but the flow is still very limited. Then we use Mustang balloon 5.0 millimeter to dilate CTO lesion with 8 to 10 millimercury, but the flow is still limited. As we mentioned, the proximal external iliac artery diameter is about 6 millimeters wide. So we repeat it with the 5.0 millimeters balloon to dilate repeatedly, but the flow is still very slow and limited. So maybe it's still undersized because the proximal is about 6 6.0 millimeter, and the CTO part is still about 5 millimeter. So we use the 6.0 millimeter to dilate the CTO lesion with less than 2 mmHg. And severe abdominal pain appeared. Then we can see the bladder. There's with contrast, that external compression that the bladder by expression by the blood extravasation. So we quickly use the extreme balloon 6.0 millimeter to have internal compression, but still have extravasation from this area. But it's really quite nervous if these complications appear. So we quickly use, as you can see, that's the extravasation from here. So we quickly use a stent graft, which is 6 millimeter to cover the dissection lesion from this area. And finally, the flow, the extravasation has been stopped. Then the CTO revascularization has been successfully done. So the risk factor associated with this rupture is the calcified vessel, the vascular stenosis, oversized balloon, history of recent endarterectomy, chronic steroid use, and diabetes. And these patients who received a mitral valve coda tendon rupture, maybe connective tissue disease should be considered. And last, medial fibrosis could be the pathophysiology of vascular rupture in younger patients. And these patients are about 44-year-old female, so which is the age is really young. So the management as below, it's a prolonged balloon tamponade.
Oh, we have to wrap up here because over time for presentation. Okay, thank you. Thank you. Okay, any comments? Just one comment from, this is very disaster because iliac artery perforation, that can be a retroperitoneal hematoma, then that's very quickly, hemodynamic compromise. So in that situation, we have to very quickly in a team. So the cover study have to go from 7 or 8 French sheets, right?
Yes.
7 French. Because so the beginning you use you have to change sheets quickly, then you switch. Then
yes.
Okay.
So it's really nervous in that situation.
And another option is from one direction you can use a balloon tamponade and prepare that sent from another direction. That is another option. So we have to do it very quickly. Okay, thank you. I think we have to thank you for that CVIF TCTAP 2020 to bring up a lot of wonderful cases, and we have a wonderful discussion regarding CTO, regarding peripheral intervention, regarding that massive pulmonary embolism. And although this is variety of intervention, however, we can have share different country, different experience, and hopefully everybody enjoy the session, and hope in the future, hopefully that Omicron is not too bad and we can meet face to face. Thank you for all the participants, and thank you again. Bye-bye.
Thank you. Bye-bye.
Bye-bye.